I'm Bengt Winblad, and I'm a clinician originally. I'm former clinician, I would say. I haven't seen patients the last 10 years, but I've been very much involved in drug discovery the last time. And before that, I was heading a big geriatric clinic and also a clinical trial center. I will give you an introduction. And how do I go this? First, I'll talk a bit about the societal impact of the disease. It's, of course, enormous due to the large number of patients getting the disease. And these are some figures from Sweden that I've taken. You can see that we total have 150,000 with dementia in Sweden. Most of them are having Alzheimer's disease. And in addition to that, we have many individuals having pre-stages of dementia. We call them mild cognitive impairment, and I will come back a bit to that later. And of course, the cost for our society are enormous. It's the most expensive disease we can speak about. And the latest figures here are that it costs Sweden, with an inhabitant number of 10 million people, 80 billion Swedish crowns a year. And you have to say 10 Swedish crowns is roughly $1 or €1. Also globally, of course, it's an enormous problem. We see every year 10 million new cases. The last years also have brought a lot of new basic knowledge. We are better understanding the mechanistic ideas behind why the nerve cells are dying too early in the disease. And we have both, I would say, genetic and environmental factors. And you can see that to the left here, you can see the amyloid beta plaques and the neurofibrillary tangles. Actually, Alois Alzheimer, who discovered the disease and described these pathological changes in 1906 already in a meeting in Germany. He also added to that the inflammatory part and some other histopathological hallmarks. And we can see that to the right here, we can see that we have sporadic cases really dominate the field. So sporadic AD, we have up to between 95 and 99% of all cases, and the familial cases who are, of course, coming a bit earlier in the lifespan, within 35 to 65 years, we have roughly between 1% and 3% of all, I would say. And we know from epidemiological studies that the environmental factors where you can do a lot to help mainly are focusing on the cardiovascular system, but you see high cholesterol levels, high blood pressure, low physical activity, and of course, diet has also an influence on the health condition of the individuals. Genetic risk factors are ApoE4, for example, increasing the risk really, and you see a large number of ApoE4 individuals in the clinical trials. This is a figure where we can see Alois Alzheimer depicted, is looking up from 1906 on what is happening. He looks very happy, I must say. He must have thought that we would have a treatment in 10 or coming 20 years after 1906, but it's actually not until in the 1990s we saw the first symptomatic treatment strategies coming up with the 3 cholinergic drugs, donepezil, galantamine, and rivastigmine. And the last approved molecule in Europe was memantine, that is an NMDA glutamate receptor antagonist, we could say, was approved in 2002 by the European authorities. And now we come to the right, to 2021 or 2023, where we see 3 new antibodies being approved: aducanumab, lecanemab, and Donanemablast. Regarding Donanemablast, we can say that it's pending approval, the process in FDA. Also very promising for me is to look on a slide by Jeff Cummings, where we can see different molecules in clinical testing phase. It's phase 1, phase 2, and phase 3. Phase 3 trials are used for approval of a molecule, of a drug, and you see that in the middle here, the middle circle here, and you can see we have biologics up to the on the top. Then we have the disease-modifying small molecules, and then we have the more symptomatic drugs to the left here. Of the disease-modifying molecules, we can see those that I mentioned, aducanumab, lecanemab, and also they mentioned solanezumab and gantenerumab. This slide was produced in 2021, so it's a bit old now. What is promising here is that we see an interest not only in beta amyloid, we also see an interest in affecting tau, affecting inflammation and other modes that could contribute to the start of the disorder. And it's also promising that we see so many small molecules in clinical testing phase. We heard Martin mentioning the small molecules really can be taken orally. They are small in size, perhaps a bit lipophilic, and will pass the difficult blood-brain barrier passage and hopefully also pass into the nerve cells later. Why is it then important clinically with an early diagnosis? I think it's important both for the patients and for the relatives to understand the disorder and the problems the patients show. It's certainly also important for the society. But the most important part, in my view, is certainly that the patient gets access to treatment before the pathology is too advanced in the brain. He or she can take part in clinical trials. What we can see here in Sweden and at our clinic is that the diagnosis today is really put much earlier. When I came to Stockholm in 1987, I think it was, I would say that we put a dementia diagnosis 10 years later than we do today. And this is mainly due to the development of biomarkers including both imaging biomarkers, positron emission tomography, magnetic resonance, but also due to biomarkers, chemical that you can measure in cerebrospinal fluid, CSF, or in blood, or in tears, or any fluid of the body, I could say. And we can see here that if we have here the time for the dementia diagnosis on the x-axis, we have a pre-stage that we call MCI, late MCI, early MCI. This is a slide from 2010. And then we have a pre-symptomatic phase that could be, like, say, 20 years before the onset of dementia. And already then we can see two parts changed here, the blue and the green line. It's showing the cerebrospinal fluid measurements of amyloid beta, and the positron emission imaging part showing amyloid content. Later, we see an increase of symptoms that is increasing close to the diagnosis. We can see that the cognition is impaired, the memory function especially, the function, the ADL functions of the patient is impaired. And in parallel, we see an increase or a decrease in fluorodeoxyglucose measurements. Tau is coming a bit later, and we can see a continuous increase of tau with the disorder here, and then it levels off during the phase of dementia, or slightly increases, we could say. So this is a bit of a Swedish specialty, the blood and CSF biomarkers. I mentioned that CSF really, cerebrospinal fluid, really reflects what is happening in the brain, but it turns out that you also can use more cheaper methods or not so invasive methods, really to just look on the blood or plasma biomarkers and what damages they reflect in the neuron, in the nerve cells. You can see also biomarkers that reflect something happening in the vessel walls, or you can see inflammatory biomarkers, or you can see metabolic biomarkers like insulin, whatever. But the main focus is on biomarkers that measure effects in the synapses or in the long myelinated parts of the neurons. And here you can see the parts measured in CSF is, for example, A beta, it's phospho-tau, it's total tau, it's NFL, reflecting more the neurodegeneration, and its inflammatory parts reflecting the inflammatory measurement or the concentration of gliosis or astrocytes in the brain. And just recently, we have seen an increased interest in measuring blood biomarkers, and we have those that we traditionally could measure, and we also have the addition now lately of the glycans that are really seem more brain specific and really can predict when a patient will develop dementia in time years ahead of diagnosis, we could say. In the US, there is a big trend to look on different phosphorylation sites of tau in the measurement. Martin mentioned that we have seen some antibodies coming up, and I'm only bringing some data from the studies on the latest two, Lecanemab, that was really developed here in Sweden by Lars Lamfeldt, and Donanemablast, that was really developed in the US, and recently Eli Lilly came with a press release of a positive phase 3 trial. What we can see, we saw it already with aducanumab, was that these antibodies that are injected intravenously could reduce the amyloid burden in the brain. And in the phase 2 trial by BioArctic, that is a really nice study, I must say, with a large number of patients, they could see that with the two highest concentrations, either given every 4th week or every 2nd week, the highest concentration then 10 milligram per kilo body weight. So a person weighing 100 kilos will have 1 gram of the antibodies injected bi-weekly in this green line. And you can see that the really the decrease of amyloid in the brain, and they claim that 81% of amyloid positive converted back to negative at this highest dosage. This was used also for the, I would say, for the rapid approval of Lecanemab by FDA, this phase 2 study, and they added the side effects that part from phase 3 to come up with this rapid approval. Lecanemab people was then licensed to Eisai and later also to Biogen, have done a large phase 3 trial. It's called Clarity, and you can see that they used as primary outcome here global measurement of cognition and function, and it's called the CDR sum of boxes. And in the study, they could show over 18 months treatment that the placebo group declined faster than those that were on active immunotherapy. And they claim that this slowing of progression was 27% better than when you compared it to the placebo approval. And if you prolong these curves, you can also see how long time, I would say, that you can keep these patients in this lower or better stage of the disease. And what was interesting for me was that the curves are divergent, but we have no idea if this will continue over the time, so we have to do more long-term studies. But it was also that all CDR sum of boxes domains like memory, orientation, judgment, community affairs, hobbies, personal care showed improvement. It favors Lecanemab in these studies. So it's, I must say, rather strong data, and just now the antibody is left to EMA for eventual approval. And if it's approved by EMA at the end of the year, then it will be the local countries that decide and discuss the pricing or the reimbursement of this antibody. The last reported positive antibody was Donanemablast from, as I mentioned, Eli Lilly, and they had a press release a bit more a week ago, and we had the top-line results from their Trailblazer study. And during 8 months treatment, they saw around the same effect. They saw 35% less cognitive and functional decline. And it was, as you see, a large study with more than 1,700 patients in. On the same time, we have to observe the side effects in studies like this, because it's not without side effects. It has to be shown that they can develop a brain edema with headache and vomiting, etc. And here they had 30% around reported side effects with the microbleeds and around 20% with brain edema. Of course, then it's obvious to compare the data for Lecanemab and versus Donanemablast. And I must say that there are differences in the study populations. You have different scales to measure the effects. And there was only one common scale, the CDR sum of boxes, but also the outcome of this scale is influenced certainly by the different study populations. So I must say, in summary, these differences make it difficult to properly compare the results from these two studies. And regarding the side effects, I would give the same reason. It's difficult to compare, to properly evaluate the reported side effects due to different populations, study populations. Still, for me, it remains a very positive feeling. These two studies really represent something new, giving us hope for the future treatment of AD. And most probably then combined therapy will come up, a combined therapy with a molecule that has some other modes of action affecting inflammation or metabolism or whatever. And it's an advantage if, as we heard, it can be a small molecule that can be taken per os, is cheap, and will pass the different barriers. We'll later hear about the two Alzheimer platforms that Alzecure are having. And it's first the alstatin, the gamma secretase modulators. We tested the gamma secretase inhibition, where it has more or less a total inhibition, and we had rather severe side effects. But now these modulators seem to be without severe side effects, and it's a very promising approach, I must say, to reach oral small molecule. And we also heard about NeuroRestore, and we'll hear more from the coming speakers on this, where we really, by peros, giving drugs orally, small molecules can influence the nerve outgrowths, the interaction between the nerves, and stave the synapses, affect the mitochondria. These are, I've written symptomatic effect, but it's certainly also probably having a disease modifying effect with this mode of action. So if I may sum up this, we have reached much further by all these trials and by the use of more individualized care, that using the biomarkers. Really, we can select today disease subtypes that are much more chemically, at least I would say, homogeneous, and we have a better effect on our treatments. And the treatments are still focusing on the main pathological hallmarks like beta amyloid, tau. We will hear more about neuroprotection. There are certainly a lot of other trials ongoing regarding Bricos, regarding inflammation, etc. Saw that in the slide by Jeff Cummings. And we also see non-pharmacological treatment strategies based on the risk inhibition, where you find risk factors mainly through the epidemiological studies. And for example, here you have the finger studies by Mia Kivipelt. So this last slide just shows my collaborators, and Angel Silas Dominguez, Western Jellick, Lars Danfeldt, Anders Frimo, and certainly Gunilla Johansson. Thank you.